Good evening, everyone, and welcome to this, our 15th COVID update. The hashtag for Slido tonight is hashtag PHN15. And I'd like to commence tonight's event by firstly acknowledging the traditional owners of the lands on which we all meet and pay my respects to elders past and present. And can I also acknowledge that this week is NAIDOC week and is an important cultural event for Aboriginal and Torres Strait Islander people. I'm sure you'll bear that in mind as we go through tonight's presentations. This evening we've got a number of speakers. We've got Dr. Kat Taylor, who's a public health physician from Central Coast Primary Public Health Unit, Dr. Tony Merritt, a physician from Hunter New England Public Health Unit. We've got Sandra Fitzgerald, who'll be providing us with an update on health pathways. Dr. Michelle Hogg, a GP from Gloucester, who's going to talk to us about video consultations and the quality of patient care. And Hannah Lane, Project Officer with Hunter New England Central Coast Primary Health Network, who will also talk to us about video consultations. At the end, we'll have a question and answer session, so please use the Slido hash PHN15, and we'll start by going to Dr. Kat Taylor. Kat, thank you.
Thanks, John. Good evening, everybody. So for those of you that don't know me, my name is Kat. I'm a public health physician, and no, that wasn't a misprint. I have sadly left the Hunter New England team and taken up residence as the Central Coast public health physician. So any Central Coast GPs, drop me a line. I'd love to hear from you. So just a brief local update. From the Central Coast perspective, we have remained very quiet with respect to COVID. So there have been 127 total cases for Central Coast to date. I mean, that includes, of course, people that have been diagnosed, whilst in quarantine on the return home. So in terms of local action, things have been very quiet. The last local case in our area was the 29th of August. And the last case of unknown source was actually way back in the 7th of April, which is a really enviable position for the coast to be in. Having said that, and I know that we always plug this message, but still too early for complacency. So testing numbers do appear to be down. There were 87 tests through the public system in the last 24 hours, and those rates are sort of stabilised at around 500 per week going through the public system, but noting that we do have a number of drive-through options that are run by private pathology providers on the coast. So check the Hunter New England Central Coast Primary Health Network website for those locations, because there have been some that have closed recently, for an up-to-date list of testing locations. Just a couple of other updates in terms of local testing news. So excitingly, Gosford Hospital now has capacity to do its own in-house testing for COVID. And what that means is that any people tested through the public clinic will have a much faster turnaround time on their tests. So previously, tests that were going through the public system were having to be referred on to North Shore or up to Pathology North. But now with the BD Max machine in Gosford, there's the capacity to turn specimens around within sort of 4 to 6 hours, which is really exciting. The other thing that I would mention locally is sewage surveillance. So some of you might have heard about the sewage surveillance program. And this is a program which initially commenced as a bit of a research project. So COVID-19 viral fragments can be detected in raw sewage. And people that carry the virus, that have become infected with the virus, can shed fragments for, around up to 6 to 8 weeks post the date of their onset of illness, although they're not considered to be infectious necessarily. And so sewage surveillance is a method of testing untreated effluent for basically fragments of viral particles. And it's a program which has been in place in various stages across New South Wales for some time now. But in terms of the Central Coast, as you know, the council is in a bit of a pickle, and so the Central Coast locations were a bit slower to come online. But I can now advise that there's testing that's happening in Kincumber, Woy Woy, Bateau Bay, and Toukley. Sewage treatment plants. And essentially, that gives coverage to the whole population that's living within what was formerly known as the Gosford local government area, as well as coverage of the tourism areas of the northern Central Coast coastal fringe. So it does not cover the entire population. So I remember hearing some comments from a GP about, not wanting to test their patients because it would be picked up in sewage surveillance if there were a local case. But unfortunately, that's not the case. There's still a real importance to testing people, especially symptomatic people. But just as you know, there's another weapon in the arsenal of keeping an eye out for potentially undetected community transmission, and that's sewage surveillance, which has now commenced on the Central Coast. So that's very exciting. In terms of actions that get triggered when a detection occurs in a sewage treatment plant, there's obviously a lot of sort of quality checks that go through and potentially repeats of samples taken. But you might have heard, for example, the recent news alert in Rouse Hill due to a sewage detection in that area, which was advice to people in that area with even the mildest of symptoms to get tested. So there's still a lot of work happening in terms of what sewage detections could mean. But essentially, it means that somebody has been in the area, either transiently or potentially lives in the area that is shedding the virus. So I would also mention that in terms of methods in the testing arsenal, serology is an option which is becoming more widely available. It has been available for some time through New South Wales Pathology, through the Westmead Lab at ICPMR. And there's now a range of public laboratories that do it, including Pathology North. My understanding is that some of the privates are also doing serology, but the assays that they're using often don't provide quantitative information, so you don't get a sort of titer estimate of the antibody level. In terms of the indication for serology, it's probably not of that much use in the primary care setting. It's primarily used for public health investigative purposes, particularly if you're, trying to investigate an illness with a suspicious exposure of somebody that perhaps that illness was sometime in the past. In terms of, if you're wanting to confirm a diagnosis for someone that's suspected to have COVID, and if you're wanting to answer questions of potential infectious risk, the recommendation is to do PCR testing of a respiratory sample. But in terms of serology, so it's a blood test. Ideally, 2 samples would be collected, so an acute specimen within 7 days of the onset of illness, followed by a convalescent, which would occur after 14 days. And that can give an idea. But often, the situation that we see serology ordered in is, if somebody had a historical illness and then previous travel, something like that, some kind of suspicious exposure, that they might be tested and found to have potentially an IgG for COVID, SARS-CoV-2. I might just stop there in terms of our local update, but that's just some of the developments that are happening locally.
Thanks, Kat, and we'll look forward to you participating in the question and answer towards the end of this evening's event. Now going to throw over to Dr. Tony Merritt, Public Health Physician from H&E PHU. Thanks, Tony.
Great, and thanks, John. Lovely to be with everyone. Lovely to see Kat. Very sad to see her go, and delighted for the Central Coast to have Kat's expertise locally there. I want to echo much of what Kat had to say. We had a new Hunter New England case today, but like many recently, it's somebody in airport quarantine who lives locally but returning from overseas, and just reinforcing how critical our border controls are going to be in the period ahead, while we dance with very low numbers, hopefully, of locally acquired COVID cases. The last locally acquired infection in Hunter New England was back at the start of August. So a great deal to celebrate there. Our local sewage surveillance reflects that too. There's now 11 sites. I think there's between 70 and 80 sites across New South Wales, and a real commitment to rolling that out more widely, as it really does appear to add utility. And we haven't had a positive in the sewerage now since late August, reflecting that early infection. So lots of great interest there. Can I just also echo Kat's encouragement to maintain our vigilance for testing? Just so critical. We've seen evidence of unsuspected transmission chains over the course of the pandemic, particularly recently, Southern Highlands, in New South Wales, our colleagues in Victoria, our friends in New Zealand. So it's just absolutely essential that, particularly this next month, while we do have this tantalising prospect of getting this virus very much under control, that anybody with those typical COVID symptoms does get a prompt test and isolates until the result's available. Unfortunately, turnaround time for so many of us now is, is in the order of 24 hours. So really minimises the inconvenience. So really critical to keep testing in Hunter, New England. Our testing numbers, excuse me, are as low as they've ever been since the pandemic started. So again, really critical that if you're seeing somebody who could feasibly have COVID, let's make sure they're tested, and that if or when COVID pops its head up again, we identify that transmission chain as early as we're given an opportunity to. So that's cases and testing. I might just add to the serology story too. So some interesting developments there. One caveat I would add is that we don't yet know enough about COVID immunity, and so it's really problematic to look at serology and be able to say anything reliably informed about whether a person has immunity and for how long. So we'd counsel against using serology to inform decisions along that basis. And an interesting development over the last couple of days, with China requiring travellers heading into mainland China to, in the 48 hours before travel, to have had both a negative deep nasal swab, a PCR test, but also serology, and specifically IgM negative in that period immediately before travel. And that may well be something we see increasingly in demand for people who are looking at travelling. Now, that's going to need to be a service provided in the private sector, and that's exercising people's thoughts and minds as we speak about how that will be delivered. It wouldn't be a service covered by Medicare. The superb serology service provided out of ICPMR and Westmead doesn't have capacity to support pre-travel serology, for example. So that's a space to watch, and there may well be demand as outflow travel to international destinations creates additional demand for serology. Locally, we've found it enormously valuable in very specific applications. So, for example, investigating people whose PCR results could be either very early infection or late infection, and the presence of COVID immunoglobulin, IgG, enormously helpful for determining whether it's new or old infection, and for searching for potential sources when we're doing upstream contact tracing. And John, I'm going to leave it there, but I'm looking forward to questions. I think that's the real value for all of us. So I look forward to being involved in a Q&A session in just a little while. Thanks very much.
Thanks so much, Tony. Surprise, it's not John, it's me. And thank you very much for that, and also to Kat. Always very interesting to hear from both of you, and so wonderful to have Kat on the Central Coast now. I'm just going to give a very brief update on health pathways on the Hunter, New England and Central Coast. And we always get asked in these webinars for the login details, so I'll just remind you again, on your screen now you should see the login details on the left for Hunter New England and on the right for Central Coast. And also just a quick reminder that there's the patient info site with lots of great information for your patients, which isn't password protected. And if you don't yet have stickers in your practices on all your computers, you can ring your PCIOs, your primary care improvement officers or practice support officers to get those stickers sent into your practice. So just a reminder about what the COVID pathways are, and you can either put COVID in the search engine or on the left in the table of contents, all the COVID pathways are second from the top. And the pathways you're probably most interested in at the moment are the practice management ones, the initial assessment and management, which is who to test and where to test and isolation requirements and things like that, the MBS items, the COVID referral page, the telehealth page, and we've also just done a bit of an update on the aged care pathways as well. With holidays coming up, I think what's probably of most interest is where we keep the health alerts and the latest case locations, and you'll find them on both the Hunter New England and the Central Coast sites on the homepage, right front and centre, and you'll also find them in these clinical editor's notes on the top of most of the COVID pathways. So you can see there since June we've had the travel advice around, the public health advice around people who've come from Victoria, and the latest COVID case locations in New South Wales. We're all hoping that we're going to have a pretty uneventful Christmas holidays on the COVID front, but if we don't, that's where you can go to find all the information. Also probably of interest is where the COVID testing centres are. Now, as you know, this changes quite regularly, but we at the Health Pathways team are now updating not only the Health Pathways site, but also the New South Wales Health site where all the COVID clinics are. So it should be one source of truth across both. You'll find in the clinical editor's notes all the private pathology places where you can send your patients when you've given them a pathology slip, and also the ones where pathology slips aren't required, where they can just turn up, which are mostly the drive-through ones. And then there's a link to that COVID-19 clinic site, which is the New South Wales Health site. So that's on the left you can see the Hunter New England site, and on the right you can see the same information for the Central Coast site. We're about to do a little bit of a chat about telehealth, so you might also be interested in the COVID-19 telehealth pathway, which hopefully will have everything on there that they're about to discuss. If not, always send us some feedback. And we've also developed a pathway specifically for our Aboriginal and Torres Strait Islander peoples, just around cultural considerations and things like that. Also just want to point out very briefly that we have added to our psychiatry and dermatology referral pages with a telepsychiatry and teledermatology referral section for our more rural colleagues and for people who are having trouble accessing those services. And can I say, as always, we love your feedback and we value improving pathways to make them more useful for you. And if you just want to say good job, we love that too. But anything you want to feedback to us, on the Central Coast site you'll find the send feedback button on the top right of every pathway, and on the Hunter New England site you'll find it on the bottom right. And so thank you very much everybody.
Thanks, Sandra. Health Pathway is always a changing space, and good to have an update on that. Thank you very much. Can I just remind you that the identifier for Slido is PHN15. So if you've got questions, we've got a few questions coming in. So if you've got any other questions, please log on and put your questions through there. Please use your name. It helps us come back to you if we need to provide information tomorrow or over the next couple of days. I'd like to now introduce Dr. Michelle Hogg and Hannah Lane. Dr. Hogg is a GP in Gloucester, and she's going to talk to us about quality patient care using video consultation. Thanks, Michelle.
Good evening, everyone. I think I'm actually here to answer the questions, and so probably we should swap over to Hannah at this point, who has prepared a talk for us on the subject.
Thanks, Michelle. Okay. I hope you can see the front page of this presentation. So thank you and good evening, everyone. My name is Hannah Lane. and I'm a project officer with the PHN working on telehealth. And as you just saw, Dr. Michelle Hogg is joining me this evening. Michelle is a specialist rural GP and obstetrician. She is the VMO at Gloucester Soldiers Memorial Hospital, and she is an experienced user of the healthdirect video call system. So the PHN's telehealth project aims to increase the use of video consultation among GPs, Aboriginal medical services, and allied health professionals. And tonight we have 3 objectives for this session. We'd like you to depart with an understanding of the rationale and benefits of offering video consultation to patients, the healthdirect video call offering, and the support and resources that are available from the PHN. Before we get into that though, I have a few questions for Michelle. So Michelle, what initially prompted you to offer video consultation to your patients?
Hello there. I think COVID was the absolute precipitant. We've all been watching in the sidelines thinking that telehealth would be a good opportunity for us to deliver care to our patients, particularly rurally, to reduce the barriers of distance, etc. But with COVID, suddenly there were a whole lot of added issues and imperatives, such as the health or the safety of our patients who might be exposed to infections in our surgeries, our own health, and also the potential difficulty of being able to deliver care if we were well but being quarantined and unable to see people. So those were the imperatives that drove us to, well, and also the availability of item numbers led us to actually following down and executing, if you like, the telehealth consultations.
Thank you. When would you say it's appropriate to use video consultation, and when might some other type of consultation be more appropriate?
I think that is a difficulty of telehealth, is in that in the triage process it is not always clear when telehealth is going to be sufficient. But I think telehealth or video conferencing is much more likely to be a close comparison to a face-to-face consultation. And so I think it's reasonable if the patient is requesting telehealth to have a go, and on some occasions you may then decide that you need to see the patient in person to complete the consultation. But there is always a lot that you can achieve in the initial context of a telehealth consultation.
Thank you. How have your patients responded to you offering video consultation?
The response has been, I guess, mixed, in that I guess not everyone's interested in the technology, and they would rather see their doctors face to face. But again, in the COVID context, we've been probably more actively promoting that we would prefer to do the telehealth in some situations. So some patients have been taken to the table, possibly reluctantly. I think once they are online and have had a successful consultation, I think the response has been very positive, and they've been keen to consider doing further consults in that way.
That's good to hear. We are going to look at some of the benefits of offering video consultation, and there are benefits for both the clinicians and the patients. So importantly, video consultation most closely replicates the face-to-face consultation experience, as Michelle mentioned, and patients do appreciate that there's a wider range of services available. Video consultation doesn't replace either face-to-face consultations where they are available and appropriate, nor does it replace telephone conversations. It supplements the service offering. So being better able to assess and communicate with patients is obviously of great benefit. There's also the flexibility for practitioners who no longer need to work from home, from a practice, surgery or facility or some other medical location, but can actually work at home and even after hours if required. There are the corresponding cost savings from travel and potentially even room and clinic space. Additionally, offering video consultation services means that practitioners can provide services to patients who come from a larger geographic area. For patients, there is also lots to be gained from video consultation, with cost savings in travel time, tolls, parking, accommodation, waiting times, and so on, as well as the convenience of being able to attend the consultation from any location at a date and time and through a device that suits them. Video consultation supports consistency and continuity of care and follow-up. And it also enables multiple health professionals to be consulted and engaged simultaneously when necessary. One patient summed it up very simply. They said, "I was more relaxed in my consultation. I was in my familiar environment and the specialist and I were both at ease. I didn't have the stress of getting the two people I cared for sorted before the 90-minute drive to the city hospital for this appointment. I saved money on fuel and parking fees. I didn't have to sit in a full waiting room. I didn't have to turn down work for that entire day because of the travel time and waiting room time blowouts. The benefits of telehealth are immense." So why promote video consultation over telephone consultation? There are two key reasons that video consultation is preferred over telephone consultation. And it's just important to remember that as we go through these, that video is not intended to replace either face-to-face or telephone consultations, but to complement them. So the reason for offering video consultation as the first alternative preference where face-to-face consultation is not available is relate to providing the best possible level of care and reducing risk for both patients and practitioners. So video consultation enables a better patient experience. Video is the most comprehensive type of consultation that practitioners can offer with the highest possible standard of care when you can't meet face-to-face. Using video, which enables the visual examination, rather than telephone, which provides audio only, makes it easier to determine whether the patient understands the information and the instructions provided. Conducting even a limited visual examination using video also minimises the risk of missing or overlooking something important in a triage or consultation. Offering video consultation also complies with the MBS requirements. So I'm sure you're all aware that the MBS online fact sheets on the new telehealth items state that video conference services are the preferred approach for substituting a face-to-face consultation. However, in response to the COVID-19 pandemic, providers can also offer audio-only services via telephone if video is not available. Now, obviously, this is a developing policy area for government, and there are likely to be changes to aspects of telehealth over time, such as the MBS item numbers and compliance. So it's very important that practices and practitioners are aware of the rules and stay on top of any changes. No practitioner will want to be in breach of the MBS guidelines or run the risk of receiving an unfavourable audit and the consequences thereof. So the easiest and simplest way to avoid this is to ensure that where face-to-face consultation is minimal or not available, you're offering video consultation as an option for patients. Those who aren't able to use it for any reason can decline and request a telephone or a face-to-face consultation instead. So in summary, supplement your existing service offering with video consultation to protect yourself, your practice, and your patients from unnecessary risk. We're now going to look at what some GPs have had to say about their experiences with video consultation. GPs frequently, in a recent RACP members survey on the new telehealth MBS items, GPs frequently mention the convenience for patients. And although it's often mentioned that the ability of older people to use video consultation is limited. Some GPs reported that in their experience, the elderly people who participated in video consultation appreciated the convenience and did adopt it. Consistent with a recent report in the British Medical Journal that video consultations are on average 4 minutes shorter than face-to-face consultations, GPs reported that more efficient use of time has enabled more frequent and shorter consultations and has also reduced costs for patients. At the same time, a number of GPs reported that attendance via video consultation has been greater than face-to-face consultations and even telephone. In one case, a GP reported that their telephone calls to older patients often went unheard and unanswered, whereas with video, patients often had a family member or a carer that would assist and ensure that they didn't miss their appointment. Finally, numerous general practitioners reported that video conferencing offered benefits for communications and for diagnosis in terms of conducting the visual examination and observing the patient's comprehension. Additional tools such as screen sharing and file sharing were also reported to be helpful for providing information to patients and their families. So I'm going to ask Dr. Michelle Hogg a couple more questions now. Michelle, when did you start using healthdirect video call?
As soon as we could get access to it, which I think was about the end of April, we started immediately trying to offer telehealth consultations with whatever platforms we could find, you know, Skype, Zoom, FaceTime, etc. But yes, as soon as the telehealth platform was available, or the healthdirect was available to us, we crossed over to that.
And what was it about healthdirect that made you choose to use that?
We have basically ease of use and consistency. We have embedded a link to the healthdirect platform on our website, and so with the other platforms we had to instruct patients in downloading programs onto computers or phones. It depended what phone they used as to how that would happen, what logins they needed. And, you know, our receptionists were struggling with time anyway, let alone having the technical skill to train everyone on what they needed to do. So the ability to have this login through the website that they just pressed on and then filled in their name was just so much simpler to organise from an organisational point of view.
Yes, that's absolutely one of the benefits. Okay, so while general video conferencing systems such as Skype and Zoom and Microsoft Teams, FaceTime and so on are widely available and they suit most computers and mobile devices, health-specific platforms are specifically designed for virtual health consultations and to preserve privacy. Okay. So healthdirect video call is compliant with the requirements of the Australian Information Commissioner and funded by the Australian Government. So both patients and practitioners can have confidence that it is private, secure and compliant with Australian law. Healthdirect video call has been designed to closely replicate the face-to-face consultation experience. As Michelle mentioned, patients receive just one link to click. They only have to enter their name and they're taken to a virtual waiting room. Just as in a face-to-face appointment, when the clinician is available, they will collect the patient from the waiting room and the consultation commences. Now, if the clinician is delayed, it's simple and easy for an administrator to message the patient and advise them when to expect the doctor. And if necessary, up to 5 participants can be included in a consultation, which means that carers, family members and other health professionals or even translators can participate. Healthdirect video call also makes it very easy to share information with patients. There is a screen share and file share function, and practitioners can mark up images and information for patients using a pointer, drawing, typing, circling, sticking markers onto certain parts of the image, and even sharing YouTube links, so that the patient can so that they can be sure that the patient understands what is being communicated. From a technical perspective, like all video conferencing software, healthdirect video call users will need a keyboard, a microphone, and a camera or webcam. So healthdirect uses the Chrome browser, which is free to download from the website that is linked on my slide, which will be available after this session. Apart from that, however, there is nothing else for them to download. There are no plugins or system requirements. They do not need an account, special software, or dial-in details. There's just a single link provided. healthdirect video call can also be used from a computer, a laptop, a tablet, or a mobile. Finally, healthdirect Australia provides lots of training and support for users. There are online videos and step-by-step guides for patients, for clinicians and administrators, as well as a help desk that is available by phone or email. There is extensive information online and detailed technical specifications for IT people if required. The PHN also provides support for setup and onboarding, which I will discuss more in a moment. So why use healthdirect video call rather than another product that's designed for video consultation? Well, firstly, healthdirect is federally funded and free for use by general practitioners in private practice and in Aboriginal community-controlled health services until March 2021 and until June 2021 for allied health professionals. Secondly, it's simple and easy to use. You can check out the features and functions available in a short demonstration from the PHN. There is great support and training available from healthdirect and from the PHN. And finally, but very importantly, it's a secure and private system which follows the Australian cyber security guidelines and stores all records in Australia. This means peace of mind for both patients and practitioners. So what specific support is the PHN offering? There are many ways that the PHN will support you to broaden your service offering to include video conferencing. Firstly, we'll help by giving you advice and support to work out how to offer video consultation to your patients. We'll do the administrative setup, and if you need equipment, we will connect you with the appropriate service providers to assist. We will give you a one-to-one demonstration to show you the healthdirect video call system and give you an opportunity to ask questions. We'll provide guides and resources to help you embed video consultation in your practice workflows. And we'll be here to help if you have further questions once you get started. So where to from here? Well, who doesn't love a good roadmap? Let's motor through the next steps. If you're interested in finding out more about telehealth or registering for healthdirect video call now, get in touch with us. There are 3 ways to do that easily tonight. First one is to email telehealth@hneccphn.com.au, and the second one is to express interest in the survey and evaluation of this session. Or thirdly, you could type us a note in the chat box now and we'll get in touch with you in due course. Secondly, we'll walk you through the process and steps to setting up and using video consultation. We will help you to compare the different options, considering how different software has comparable or different features in terms of cost, in terms of functions, risk, privacy, and security. We'll give you a short and simple demonstration of healthdirect video call, and we will answer your questions and share our resources. So on that note, it's time for some questions. We'd love to know what's on your mind. Is it the technicalities of healthdirect video call and the features and functions it offers? Is it technical setup, whether you have the right equipment and internet speed? Is it your patients, their capability, willingness and understanding of telehealth? Or is it education, training and ongoing support, or something else? While you submit your questions, I will ask Michelle a couple more. Michelle, what would you say to practitioners who think that telephone consultations are adequate and video call is extra work for little benefit?
Look, I just completely disagree. To me, I am pleased that we now have the opportunity to be remunerated for the work that we do over the telephone. But what I think can be achieved in a telephone consultation is just completely different to what can be achieved in a video consultation. I think the telephone is appropriate for delivering results to people, checking on people who we've already assessed, but for an actual clinical assessment, the video consultation is far superior. You can get the visual cues that are so important in general practice. And interestingly, some of those visual cues are stuff that you don't have access to in your consulting room. So, the patients are more relaxed in their own environment. You can see the interaction with children running around, whether they're stressed by that, relaxed. You can get a little bit of an insight into what the home looks like. So there are all sorts of added information and cues that form part of your assessment that just isn't available through the telephone. So, yes, I would strongly recommend telehealth consultations wherever available and possible.
Thank you. And finally, do you have some advice for other practitioners who might be starting out with video consults or seeking to achieve best practice?
Well, I guess the first thing is just to give it a go. Until you've tried it, it's all a bit uncertain as to how it will work, but it's not expensive to start, particularly with the free access to the platform that we're talking about tonight. So all you need is a camera, which I think is under $100. So it's well worthwhile giving it a go and seeing how it works for you. And I think it really opens up lots of opportunities for the future care of our patients.
Thank you very much for sharing your experience, Michelle, and your insights with us. Now, before I finish and we open the question and answer time, I'm going to leave our audience tonight with a few key resources that will be available after this session. So a reminder that if you want to register or ask any further questions about healthdirect video call or video consultation in general, the email address to use is telehealth@hneccphn.com.au. Second one, make sure you're familiar with the MBS telehealth fact sheets and the appropriate item numbers to use. Thirdly, very soon we'll be launching a dedicated telehealth webpage on our new website where you'll be able to find information for both practitioners and patients about telehealth, particularly how and when to use video consultation, what best practice video consultation looks like, privacy, practice workflows, equipment, IT, patient tips, questions and answers, and much more, including links to additional resources and videos. Finally, there's a 30-minute webinar that was recorded by the PHN earlier this year, which gives advice as to how to best manage a practice's appointment book using the new MBS items for telehealth. This will help you to ensure that your practice continues to run smoothly, remain compliant, and provide quality patient care. So these resources are a great place to start on the journey of expanding your service offering to include video consultation, and we hope that you find them useful. Thank you for your time and attention. We look forward to your questions and comments.
Thanks, Michelle, and thanks, Hannah. We've got a couple of questions, and I might ask Hannah if she could take these on. The first question is, are With telehealth, are patients able to record their consultation?
I believe the answer is yes. I think it depends on what device that they're using, but the advice for best practice is that the consultations aren't recorded unless there's a clinical reason and a necessity to do so. So the healthdirect system and other medical specific systems are not defaulting to recording, and good practice, including the tips that are on our new website that's coming shortly, will say that practitioners should advise the patient that they are not recording the session and that they would ask the patient also not to record the session. And
Thanks,
with the
Hannah.
caveat that there may be an exception for that reason.
Thanks, Hannah. Next question is, my practice doesn't have a computer with a camera. Can we use an iPad or iPhone with the healthdirect app?
Yes, I believe so.
And
If
finally, when considering platforms for video consults, do you have a particular recommendation? Yes, we do. It's healthdirect. And is Zoom appropriate? Contact our telehealth email address and we'll provide you with the details on the various merits of the systems that are available. Thanks again, Hannah. Thanks, Michelle. Appreciate your time tonight. We're going to now move to some of the questions for our public health physicians. And question for Kat. When can general practices anticipate stop asking patients to wear masks as they forget to wear them and the practice has to buy them? I think this is related to the orange amber or the amber alert in New South Wales, Kat.
Thank you, John, and certainly that is the $64,000 question. So that is really discussions that have been occurring at a state level. So discussions that are occurring at the ministry between the Chief Health Officer and also working group from the Clinical Excellence Commission, who I believe were responsible for the initial Amber Alert, which remains in place in New South Wales health facilities. So we are still getting questions about when that's going to happen for New South Wales health facilities, but it remains in place at present. Our understanding is that, you know, if and when there is a move back to green, that there will be some further guidelines around what the new normal looks like, because there are likely to be some additional ongoing precautions. Obviously, we're going to be living with COVID for some time, and it's, you know, still going to be many months before there's going to be adequate protection from a vaccine. So unfortunately for frontline clinicians, of which general practitioners are certainly, there's probably likely to be some ongoing sort of enhanced protective recommendations. Tony, did you have any further comments or insights?
No, thanks, Kat. We're waiting to see what comes down from Ministry and CEC, and it's a question often raised with us from clinical colleagues, general practice and hospital settings. So we watch and wait.
Thanks, Tony and Kat. The next question is in relation to spirometry. When will we be doing spirometry again? I take it the question is. Tony?
Pleasure. Well, again, for issues like this, where the core infection control challenge with spirometry is that it's a droplet and aerosol generating procedure, clearly. And if that was to be done on someone who did have COVID in their nasopharynx, then clearly potential for transmission. So we're in the hands of the infection control experts and the Clinical Excellence Commission in particular, and their documents on infection control, including very specifically procedures like spirometry, are the ones that we rely on. And so spirometry can be done. I appreciate we all recognise that, but the advice continues to be that that's done with with droplet and contact precautions in place. So perhaps the question is, when do we envisage that might not be required? And again, that's going to depend on the evolving epidemiology of COVID locally. At the moment, those recommendations remain in place. So we'd recommend droplet precautions for people having spirometry done. So clearly that implies, that spirometry be done where it's just critical to the management of someone's health, and then with appropriate in an appropriate room with appropriate droplet precautions in place for everyone involved. Thanks, John.
Thanks, Tony. I might send the next question your way as well. For patients with ongoing fatigue after a severe respiratory illness, but have had a negative viral PCR, is there a role for COVID serology, and how much does it cost?
Look, I saw there's a couple of great questions there about serology. Can I just clarify one point that I made? So that the Medicare rebate does not apply for serology that's being sought pre-travel in someone who's perfectly healthy seeking serology as part of a requirement for travel. So that's the circumstance I'm aware of where the rebate wouldn't apply. It does apply for serology collected in the process of clinical investigation and appropriate healthcare management of people. Apologies for any confusion caused there. And look, serology clearly has a role where there's a strong suspicion of COVID, and having established that would be of material benefit either from a public health or immediate clinical point of view. And so there are circumstances where the prior probability of someone having COVID was really high, COVID, really strongly suspected, but with a negative PCR, perhaps because the symptoms had resolved such that the PCR might reasonably have been expected to be negative. And in circumstances where that offers material benefit, then there is a role for serology. As always, serology is an imperfect beast, and so it's critical to only order when your suspicion around COVID really is substantial, because we know there can be false positives for any test, and that's clearly not going to be helpful. Thanks, John.
Thanks, Tony. I might go to Kat with this next one, which is around swabbing. Who should or shouldn't have a swab to help community surveillance and help protect the community from possible but unlikely COVID? So I'm interpreting that as being swabbing for the sake of it without symptoms, is the way I read that, Kat.
Thanks, John. Just briefly to follow on from what Tony was saying about serology, I'd certainly echo those sentiments. And another question that's been posed to us is, should I, collect serology to check if this person is immune? I suppose an important caveat is, we're still learning about serology, and the science of antibodies is imperfect for many infectious diseases. So there's still not really much known in terms of correlates of protection, or indeed, the persistence of antibodies and their ongoing durability of protection against reinfection. So I suppose that's just another consideration, that it's probably not going to be of material benefit in confirming or excluding whether or not somebody's immune. To the question of swabbing, I'm not quite sure how to interpret this question. I think I'm taking it with the previous comment about adults and children presenting daily with hay fever type symptoms, and obviously change of season, and then also we've noticed certainly respiratory viruses such as RSV on the rise just in recent times. I suppose there are two ways of thinking about it. At an individual level, when you think what is the probability that this person has COVID, but also at a public health level, which is where we are really going pedal to the metal of trying to identify and extinguish any potential undetected chains of community transmission, which is quite a unique and probably time-limited situation that we're in New South Wales and really in Australia. So increasingly, the states and territories are, starting to arrive at this goal of no community transmission. And, things are looking quite promising in Victoria. I think they're perhaps up to 8 or 9 days now with no new cases. And so, as borders open up and as mixing increases with the festive season, there's certainly a critical window just in the next couple of weeks of really needing to identify any people that may be harbouring the virus undetected. And so I would really, although I realise that there is fatigue amongst both the community and practitioners in terms of the testing message, I would really strongly encourage still to be testing anybody that has potentially clinically compatible symptoms, however mild. And, that's really just with the purpose of trying to drive numbers down. And we are still getting the occasional surprise. So, recently there was that family cluster in the Southern Highlands, which to date, no source has been identified. So, there are movements of people. There are, despite, borders being closed, there are still people coming across on exemptions and people coming from internationally with compassionate reasons. So there still remains a risk of COVID in the community, despite there being, no local cases in the Hunter and Central Coast area. So I think it's really critical that we do maintain vigilance, particularly in this period in the lead up to Christmas. So I would suggest, yes, if people have new onset respiratory symptoms, that they should absolutely be swabbed. I suppose there is a question if those symptoms are persistent and whether there should be repeated swabbing on people with persistent symptoms, which may be compatible with what you know of their yearly pattern of seasonal allergic rhinitis. In that situation, it might be worth focusing on perhaps the people that are at higher risk of spreading the disease. If there's sort of a higher cost should COVID be undetected. So healthcare workers, aged care workers, for example, if people in those kinds of higher risk settings have ongoing allergic rhinitis symptoms, then there may be an argument for repeated swabbing if they remain symptomatic. But certainly anybody with new onset symptoms or anybody with a change in symptoms from their usual allergic rhinitis symptoms, I would still be recommending to swab them. And fortunately, it's become a lot less traumatic. I can attest to this myself, having had 4 or 5 this season, owing to having a small toddler in my household. But essentially, it's sort of just that anterior, bilateral, nasal and throat swabbing, and much more convenient with the plethora of drive-through and other options around today.
Thanks, Kat. I think that's the last of our questions. Just a couple of things. Just wanted to highlight for you our vaccine update on the 16th. So that's next Monday at 6:30 p.m, where we'll have people from both LHDs presenting, discussing the issue of vaccine and providing us with an update on that. Can I thank all of our speakers, Tony Merritt, Kat Taylor, Sandra Fitzgerald, Michelle Hogg and Hannah Lane for their time tonight, and thank you for participating. Thanks, have a good night.
Get enough sleep.